Good morning, good afternoon, good evening to all of you. And it's a great privilege to have another episode of Code, that is Residence and the Continuing Dental Education Program. Today, we are privileged to have Dr. Vinay K. Madhavan with us. I will extend a warm welcome to all our alumni, faculty, PG students, and students who are part of this today's program. I want to welcome Dr. Angelina Daniel, who is the professor and head of the department, who is from the 94 batch, whom I am requesting to introduce the speaker for today.
Hello, everyone. It's my special joy to introduce you to our guest speaker for today's presentation. He's our own CDCI, Dr. Vinay Margaret. He is a graduate of CDC and he finished his graduation in the year of 2006. And after that, he served the stage for 2 years, in which he served oral surgery department and orthodontics. Then he went abroad and he did his MBA, then his DBS, and presently he is pursuing his post-graduation in University of Maryland, Baltimore, US in prosthodontics. He did a certified courses in implantology, CAD/CAM technology, laser competency, Invisalign and iTero element scanning, and conscious sedation. It's my pleasure to introduce you, Dr. Vinay Mathur. And I, very happy to introduce you because I always felt when you change your stream to MBA, I felt that such a skillful person leaving dentistry, joining something else. I really felt very bad.
Great decision then.
That,
Looks like you made a great decision then.
Good.
and
Maybe
now
someone
it will
can
be
fix me again.
a lot of pleasure and satisfaction that you are doing a great job. Both you, Dr. Vinay Mathur.
Thank you, Dr. Angelina. So good to see you and hear from you. In 2006, I worked with Dr. Angelina in Department of Orthodontics, so that was a while back. I can't believe I'm here now, but thank you so much for your kind words. Can you all hear me and see my screen?
Yes.
Okay. I'm gonna get started. I think Dr. Nirmal Kurian got in touch with me to try and see if I can talk a little bit about digital workflow for full arch implant restorations. So just a little bit about implant restorations in the US. There is more and more implants that's being placed every day. But more than implants, what we encounter in Department of Prosthodontics is a lot of complications. I'm sure it's the same at CDC too. As prosthodontists, very rarely patients come to us as a first goal of treatment to receive implants, but most of the time, we are basically the last hope for these patients to help and rehabilitate them. So I think, digital workflow is great because there's so much advancement in technology. Things have changed so much. And congratulations to everybody who's in CDC. I think it's a great school. I received wonderful education there. And I'm very passionate about what I do right now. And the residency is just teaching me so much. I practiced as a general dentist for about 8 years, but I realized how little I know once I came into residency. So I'm glad everybody here are in the university, and I think Pros department and oral surgery department together are doing wonderful things in CDC. So congratulations on that. So just moving forward, just kind of giving an introduction of digital dentistry. Obviously, there's analog and digital dentistry. More and more people have been inclined towards doing digital dentistry. And is this our future? If you think about it, there is a lot of advancement in various fields of dentistry, and digital dentistry has completely taken over. So if you see a little graph from where digital dentistry has progressed in the last 20, 30 years, versus what happened in the last 5 to 10 years, it's just incredible. I mean, it's completely exponential growth. And I think if you are not aware of a lot of digital technology and a lot of implications of digital workflow in dentistry, especially in prosthodontics, I think we're going to be left behind quite a bit. I think we can do a great deal of service to our patients by incorporating digital dentistry into our dental skills. Of course, digital dentistry also gives us a lot of precision and reproducibility. and reduce manpower, which is really difficult to find in the US, unfortunately. There's lesser and lesser skillful lab technicians who can stack porcelain. So the manpower is getting pretty extinct, more or less. So more and more people are turning towards digital dentistry where they can actually control things. And if you're a prosthodontist, I'm sure you're very well aware that we're very particular about certain things. And if the lab or if there's not a lot of communication between you and the lab, things just didn't go the way you want them to go. There's a lot of time wastage, patients not feeling happy about it. There's a lot of financial wastage too. So sending work back and forth. So I think digital dentistry has completely changed the way we practice. I think in my life, I was practicing as a general dentistry, in general dentistry for a very long time. I was using some amount of digital dentistry. When I came into prosthodontics, my whole scope of digital dentistry has changed. So I think there's just so much more to look forward to. As far as digital dentistry, it's just not the best thing, but it is getting there at some point of time. It will be, but you definitely have to have your conventional skills. You cannot straight away go into digital dentistry. You have to know your basic skills. You have to know the conventional way of doing things. That way, digital dentistry can help you expedite or maybe refine your skills and things like those. So as a result, there is a mixed analog and a digital workflow, basically a combination of both techniques. There's limitations and advantages of both. And then moving forward, some of these advantages, I don't want to go over them because of lack of time, but most importantly, there is a simplified implant impression technique. There's virtual assessment of implant prosthetic space. And as prosthodontists, we're aware that prosthetic space is really a key in order for our prosthesis to be successful. We're very fortunate to have some skillful surgeons to work with, but surgeons are very skillful in the way they do the surgery. But when it comes to the prosthetic space, if you do not have the prosthetic space, we as prosthodontists know that things are going to fail. And patients usually come back to a prosthodontist. Very rarely they go back to a surgeon and say that my prosthesis is fractured or I'm not happy with the way my teeth look. So I think having a good assessment of the prosthetic space is really important, and digital workflow helps us plan all this ahead of time. That way we don't encounter any hiccups or failures with time. There's obviously improved workflow between the lab and the dentist or the provider itself. You can communicate with the lab a lot more easier. You can email STL files. You can do a Zoom conference, just like what we're doing, go over the cases. It's so much more easier to communicate with the lab versus trying to send all your articulators, your casts, your whole workup back to the lab, and then not being able to communicate well. So obviously it's more comfortable for the patient. And as far as storage, you can electronically store all these files. Say, for example, you do a digital wax up, you don't like the position of certain teeth, you can actually save that file and you can move those. That way you don't have to do a lot of wastage of your time trying to modify things. So these are some of the advantages of digital technology in full arch restoration. Now, of course, just like any other procedures, there are some limitations. As far as limitations, there is huge amount of cost. As a dentist or as a practicing provider outside, there's only a certain amount of digital technology that you can incorporate, because some of these machinery is way too expensive for a single sole practice owner to purchase all this. So if you're in a big group practice or if you're in a university, yes, you have the ability to use a lot of scanners, you have the ability to use a lot of milling machines, but if you're a sole provider, these can be very expensive. So there is obviously a learning curve like any other digital technology or software. There's so many scanners these days. So there is definitely a learning curve. The more you do, the better you get at it, the more accurate your digital impressions are going to be. And the most important thing is there's not enough scientific data about the accuracy of digital impression making technologies in comparison to the conventional ones, especially in regards to multiple implant impressions. So if you have a patient who has single implant restoration that needs to be done, you place a scan body, you go ahead and scan it, you have teeth as a reference, you have so many adjacent structures that can help you align and make sure that your prosthesis is more predictable. When it comes to a full arch restoration, because you don't have any hard tissues to compare, there's some amount of discrepancy where you try to merge scans. It is really not that accurate. So Of course, there is more and more advancements every day, and things are becoming more and more accurate, more and more better. But I don't think it's still there yet. At least at the University of Maryland, we strongly believe in a combination of conventional and digital. So I'm going to show you most of our cases are mostly conventional and digital. The place where I used to practice before, they used to do mostly digital. So I just incorporated one or two slides. That way you kind of know what is there too. Um, so just let's quickly dive over some cases. I have a lot of information. I'm going to try and cover as much as possible. Towards the end of the presentation, maybe we can go over some of your questions if you have any. But I'm just going to quickly present a few cases. Now, this is one of our patients. He's an edentulous patient. As you know, most of these patients who want full arch restorations are either edentulous or they have teeth that are non-restorable and they're looking for some kind of a replacement option. Now, the most important thing is when the patient comes to us, the key role is to diagnose. I mean, if you cannot diagnose properly, you cannot treatment plan properly, regardless how skillful you are, your treatment is going to fail. So I think the most important thing is to diagnose and have a very wonderful treatment plan and a sequence, and just know what you're going to do. See the end point. I think that's going to help your workflow go so much better, less complications with time, and easier for everybody. So this patient is edentulous. As you can see, this is a maxillary and mandibular ridge. He had recent extractions done. He was wearing some immediate dentures at that point of time. Things have healed pretty, well. And this is a approximate interarch distance, as you can see. So as a, I'm just gonna skip a lot of these steps. I'm sure these are very, basic. Patients like this come in, we wanna make sure we establish the incisal edge position. We wanna establish the occlusal plane. We wanna make sure that patients is not having any discomfort in terms of his joint and things like those. So once you have all these checked out, you go ahead and fabricate him. These are called interim dentures. If your immediate dentures are good, that's great. But most of the time, as we all know, that the immediate dentures do not work that well. So your incisal edge position is not at the right place. Your occlusal plane is probably a little canted. So we always go through something called as an interim denture. That way we are for sure finalizing all these findings. So this is an interim dentures that we fabricated for him, both maxillary and mandibular. And once you have fabricated the interim dentures, we go ahead and do a dual scan. A dual scan is usually done in patients who are edentulous. That means you scan or you put markers on the denture, you take the patient to get the CT scan. Now you do two kinds of scan. One is the patient gets a CT scan with the denture in the mouth with the markers. We can use Shure markers, you can use gutta percha, you can use composite, anything that is radio opaque, you could use those. And then the second scan is the scan just of the denture, and then these scan markers help you align the denture or the tooth position in relationship to the CT scan. So this is basically his CT scan. As you can see, these little white dots that you see in the CT scan are markers on his dentures, both maxillary and mandibular. These help us align the two scans together. So you need to make sure that your denture is well fitting. So if you're using an immediate denture, because your interim denture is going to act like a surgical guide. So if you're using an immediate denture that's not well fitting, your guide and your implant planning is not going to be accurate. So it's one additional step of making an interim denture, but it really helps you have a more predictable plan. Now, we use a lot of software here in our university. Most importantly, as far as implant planning, we use the Blue Sky Bio, we use Implant Studio. These are the primarily, these are the most important ones that we use. We have other ExoCAD, we have 3Shape, we have DTX, we have various other software, but these are the two for implant planning. One is the Implant Studio, and then we use Blue Sky Bio. This plan is in Blue Sky Bio, so you want to go ahead and plan your implants based on the CT scan and the findings. This patient was planned for 6 implants in the maxillary arch. And then, of course, you want to know your space requirements. So this also, with the help of a denture, it will help you evaluate how much bone reduction you need. Most individuals, when they're edentulous, they usually have some amount of bone, but you don't want to reduce more than necessary. You just want to have enough prosthetic space. So these are some of the requirements for prosthetic space. Most of the prostheses that we do here in the US are zirconia and metal acrylic or porcelain fused to metal. We very rarely do metal ceramic. We we don't do metal acrylic as much. It's mostly considered as a provisional kind of a restoration. As we all know, staining, wearing of acrylic teeth and things like those, but you also need more thickness for metal acrylic for your metal bar and acrylic to go on top of it. So these are some of the basic requirements for full arch prosthetic materials. Now, this is an implant planning in Blue Sky Bio. As you can see, these are the radio opaque markers. This is a denture that you see, and then the implant which is being planned. You want to plan all these implants as far as the spacing you can measure from your occlusal plane to the fixture level, head of the fixture. You also need to incorporate multi-units. So multi-units come in, if it's a 17 or a 30 degree, you want to have at least a 2 to 3 millimeters of leeway space. So that's why you have the 15 millimeters instead of 12, because we're going to be using a multi-unit in this area. Now, this is an implant planning after the bone segmentation is done in Blue Sky Bio. We go ahead and fabricate our guide. Now, as I mentioned, this is the interim denture that's also using as this being used as a guide. So if you're using your immediate denture, your guide might not be that accurate because it needs to sit really intimately to the tissues. But if you think like if your immediate dentures are good, you can always reline your denture just before the patient goes in for the scan. That way there is good intimate adaptation of the denture intaglio to the surface of the tissues. So these are the anchor pins. You want to stabilize your guide, and this is the same denture. We go ahead and fabricate surgical guide. All this is done basically in-house. We do everything at the university. We rarely send anything out. The only thing that we send out is for milling a bar. We don't mill a bar. And if we're doing metal ceramic restorations, we don't stack as much porcelain. We're not that skillful, so we usually send it out to the lab. But other than that, all this work is actually done in our university. We have a huge lab, a lot of milling machines. So we do all these printing and milling more or less in our university here. So these are 3D printed surgical guides, maxillary and mandibular, and you go in for your surgery. This is a bone reduction guide. You place in there, you go ahead and reduce your bone because you already know how much bone reduction that needs to be done in order for you to have the adequate amount of prosthetic space. You go ahead and reduce the bone, put in your, so these anchor pins are obviously pretty stable. You want to have at least 3 to 4. 3 is usually good. This is a denture. You cut it off in the palatal area. That way you can reflect your flap. Sometimes the flaps is in the way. The guide might not see that accurately. Now, I can't say this is 100% accurate, but it is way better than doing a lot of freehand surgery, which is still okay. A lot of skillful surgeons can do a freehand surgery. But then when it comes to replacing the teeth with the help of prosthesis, you're going to encounter a lot of issues. So I think this is obviously better than doing a freehand. So I wouldn't say it's 100% accurate, but you get pretty close to where you want your implants and your prosthesis to be. Again, you go ahead and place your implants. Implants are being placed, and then you go ahead and pick up your prosthesis. This is immediately loaded, the maxillary arch, the interim denture. Once it's immediately loaded, patients go home with that denture that same day. Now, once the patients come back, or that same day when you're immediately loading, once you place these are straight abutments in the anteriors and then a multi-unit angulated ones in the posterior. As you see, compared to your plan and what you actually executed, it's more or less very similar. I mean, your implant location, where you want those implants to come out from in your final prosthesis. So it's obviously a little bit more predictable. Is it perfect? Probably not, but it is definitely a lot closer than trying to do this freehand, because those little angulations, that a 2-3 degree angulation means a lot in prosthesis. So an implant that is supposed to be coming out more lingually, if it's 3 degrees off, which is not a lot, it can come out facially, which can be a big problem for us when you're trying to restore it. So again, go ahead and place multi-units, temp cylinders on there. You pick up the prosthesis and have the patient go home with it. So this is one way of doing it. Again, all this denture work is, you could either mill the denture, you can print the denture. There's various ways of doing it, or you could do a conventional denture and then go from there. So this is basically a mix of analog and digital. Now, my next case is going to be an XNAV case. We do a lot of XNAV in our university. I don't know if everybody is familiar with XNAV kind of surgeries, but this is another case. A patient of ours came in with some periodontally compromised teeth, a lot of carious teeth. As you can see, occlusal plane is all over the place. Teeth are shifted or migrated. So you want to determine the occlusal plane. You want to determine the incisal edge position. You cannot build the patient back to this exact aesthetics because the patients are coming to you to have improved aesthetics. So if the patient is edentulous, you're making a denture to determine the incisal edge position, occlusal plane. But when a patient comes with a lot of teeth, it's really hard to determine. So what do you do? So it's a little different than what we discussed before, where the patient was edentulous, where you have a little bit more control. But this is how his teeth look, a lot of carious teeth. As you can see, mandibular teeth are still restorable. So we went ahead and restored the mandibular teeth. But maxillary teeth were more or less hopeless because of the caries. Patient wasn't happy with the aesthetics and he decided to have those extracted. Now you go ahead and scan these maxillary and mandibular arches. You get these STL files. You go ahead and digitally articulate them. In some cases, you might want to increase the vertical. In those cases, you have other ways to articulate. But in this case, we really did not have to increase his vertical or challenge his vertical. He had adequate facial proportions. So we went ahead and articulated at the same established centric for him. Now this is a digital wax up that you do. As you can see, the difference here, this is where the teeth position are. As you saw in the patient's face, the teeth appeared to be flayed out quite a bit. So you want to go ahead and establish your incisal edge position and your tooth position at the right location. So you go ahead and do a digital wax up. Now there is no way for us to try this on, unfortunately. So that's why it's important to have all these information ahead of time, patients' pictures, patients' intraoral STL models and files and things like those. Now, as you can see, this is where his original teeth are. And this is where we want to establish them. So we go ahead and overlay them on top of each other. That way we see the difference. Now, this is an ExoCAD link. I don't know, I really don't know if I should do this, but let me see if I can. Can you see this? Can you see this?
Yes.
So, okay, this is an ExoCAD link. As you can see, you go ahead and import the STL file. This is not the same patient's file, but you can go ahead and do your wax up, maxilla, mandible, whatever you want to do. You go ahead and move your teeth around and do all these changes that you want to do. And then you go ahead and build a prosthesis based on your finalized teeth positions. Once you overlay this case is done by XNav. So we import this into XGuide, which is a planning software for XNav. And we go ahead and plan the implants. So these are all the implants which are planned with the help of sinus lifts in the posteriors. Anteriors do not need sinus lifts. So went ahead and planned these. As you can see, a little bit of bone reduction. Now you can measure, this is the pink one is where the teeth need to be. So you can measure the height of your prosthesis and either you can submerge the implant depending on that, how much bone reduction you need and things like those. So you go ahead and plan all the implants. These were planned for 6 implants in the maxillary arch. This is the XNav equipment that we use. The hand pieces, any hand piece can go on top of it. These are the trackers that we use. This is a calibrating disc. This is a wrench. This is a wrench to kind of tighten up this hand piece on top of it. And this is a plate that is helping you to calibrate every time you change your drills. So go ahead and plan your new prosthesis. What we do in school here is we're trying out a new technology. Now, XNav uses an X-clip that has 3 fiduciary markers that help orient the scan, intraoral scan to the DICOM file or the CT scan. Now we want to eliminate the X-clip because we're going to be extracting all the teeth in this patient. So we've tried out something a little different. So this is purely, still in process where we are trying to develop this kind of a technique. So you use these anchor pins on for the patient. You go ahead and this is basically the guide that helps you anchor those 2 anchor pins. So it sits on the teeth, the anchor pins go in, and then you go ahead and remove this guide, and then you put the next guide, which is this one, which helps put on the tracker. So this has a little end in the bottom right there that helps place the tracker. And these are the prostheses. This is an immediate load prosthesis that is fabricated. It's more like a stackable guide, which everything is done in-house. So you can use a lot of companies that help you do stackable guides as well. And we also make an immediate denture right there. As you can see, in case the implants don't integrate or if things don't go well, you always have to have an immediate denture. Now, the XNav, the way it works is it has two cameras right there. And one camera tracks the tracker on the handpiece, and the other one is on the clip itself. Now, because we're not going to be using a clip, we actually devise this little equipment that fits one of the little ball tracker so the camera can detect it. So we go ahead and this is our surgical team. That's me there. This are some of my colleagues. This patient was under IV sedation here. So we went ahead and get a little breakdown of all our products here. We got the immediate load prosthesis. We got the bone reduction guide. We have two just in case other immediate loaded prosthesis. Now these are not stained. This is an immediate denture. It comes, we usually use it in a box like this and get it ready for the surgery. Now the patient did want the same kind of appearance of his teeth. So you will see that his denture is not like the conventional great looking denture. The teeth are a little bit more ragged to make it more natural looking for him. But we also had an immediate denture ready for him just in case the implant did not integrate or if there was not a lot of stability for those implants. Now these are the equipment that we use for the XNav. These are the clips or the stabilizing areas where you have the screws and then stabilize it into the maxillary arch. The surgery goes on. Now this needs a very big flap because the XNav, we want to have it all the way up top here. So that's the fixation guide. We place a fixation guide. Once the fixation guide is placed, we go ahead and put these screws in to kind of fixate it. Went ahead and once the guide is being placed, we extract the teeth. And then this is the bone reduction guide that goes in the same position. Now these, obviously those little holes where you do the fixation, those are pretty constant because all these guides are made from the similar kind of an STL file. So these are all calibrated to fit onto the same spot. As you can see, this is a calibration plate. So every time you're changing a drill, there's a pilot drill, there's the 2.2 drill, the implant position. Every time you're changing the drill, you want to use this plate to help you orient it to go into the right spot. So we'll go ahead and place the implants in the maxillary arch. Again, these are all the implants that have been calibrated on the plate. This is the calibration tool. So as you're doing the surgery, you're actually not looking in the patient's mouth, but actually you're looking at the screen. Now this is a device that helps you kind of go in the right direction. This is where your implant is being planned. This is where your drill is being going into that implant plan site. So if you're deviating, then basically you just change the position. So this is something that's going to help you orient your handpiece back.
Recording in progress.
And then go into the right. So these are the implants placed. We placed the pickup prosthesis because they had pretty good stability. We place the temp cylinders and go ahead and pick up the prosthesis. That's the final picked up prosthesis on the day of the surgery. Again, the patient walks home with the help of fixed teeth. Again, immediate load it has great advantages. There's a lot of literature. We can talk about it another time because of lack of time. I wouldn't go in depth, but we do a lot of immediate loads here, at least in the US. But of course, when the implants are not integrated or if there's compromised conditions, then you have to send the patient home with the help of dentures. So we went ahead and placed the mandibular implants, maxillary implants, temp cylinders, loaded the prosthesis, and the patient goes home. Now, this is the practice that where I was before. I just placed it in here. We do not use these photogrammetry, but the practice there was using it. So in order for us to pick up the implant location, you can also use these photogrammetry tools. This is a facial scanner that you can use for the patient. Helps orient in a 3D orientation where you want the teeth to be, the buccal corridor and things like that. That way you have a little more predictable outcome. I mean, patients have all these, all these parameters that can be visualized ahead of time. That way everything goes on pretty smoothly. Now, as far as your final step, you start make sure your implants are integrated and you start making your final impression. You need to verify your cache, jaw records, teeth try-in. You fabricate your metal framework if you're doing acrylic or your ceramo-metal, or you do your prototype if you're doing zirconia, and then you do a final try-in. Either you process or mill your final prosthesis, and then you go ahead and deliver an occlusal device. Now, occlusal guard is something that we deliver for all our patients who undergo full arch restorations. This is 3Shape. We usually design everything in our 3Shape here, the software. This is a full arch prosthesis that's been designed, a prototype. Once the patient goes through surgery, once everything is integrated, you go ahead and pick up the implant positions and you scan all these. You make these little notches on your cast. That way you can orient your cast. If you have 2 or 3 different kind of cast, you can orient them as well. You go ahead and fabricate your prototype. Once you fabricate your prototype, you go ahead and try it in, maxillary mandibular prototype. Make sure patient is happy with the aesthetics. This is the same patient who was edentulous. This is the prototype that's been tried in. Now you have 2 choices. Either you send the patient home with the prototype, make sure he's happy with this, his family members are happy with it, his aesthetics, phonetics, everything is tested out. Or if you're very confident, you don't have to send the patient with this prototype. You use this prototype to do it as a try-in. You remove the prototype, you put the old provisional back in and use this to help you mill the final prosthesis. But sometimes we let the patient try it out for a week or so. He goes home, tries it out, and comes back. Now, this is the final, like I said, prototype. Once the patient is happy, we go ahead and get to the next step. Now, this is another case. Once the prototype is done, typically we re-articulate it and then get it back in our software. We use a milling machine. Here we use argon zirconia pucks to mill it, and we do some intraoral staining. The zirconia can still maintain the staining part, and then we sinter it, and then we do some external staining after that. Now, this is one of the zirconia prosthesis, mandibular zirconia prosthesis that was done in-house. The staining and glazing, everything is completed, ready to be delivered. This is the patient. This is a different patient, but again, similar kind of prosthesis. Once you pick up the implant location, you're doing a prototype trying. Once the prototype is good, you mill the zirconia prosthesis, you sinter it, stain and glaze, and finally deliver it. So that's the mandibular prosthesis that was delivered. So everything, like I said, you can digitally incorporate all this into your workflow and help you deliver these prostheses on a routine basis. Now, this is another case that came into our clinic. Implants were placed elsewhere. They had placed some kind of a temporary or a provisional restoration, and patient was unhappy with the way it looks. So she came to our clinic trying to see if we can do something to address this. As you can see, the occlusal plane is completely canted. She has some missing teeth in the mandibular arch and a lot of staining, irregular prosthesis, not the very best looking prosthesis. In the mandibular arch, she has the 2 implants placed here. She's the edentulous in the posterior area, but she did not want to have any more implants done to restore the posterior. She just wanted to finish her case. So we went ahead and did an implant level impression for her, a fixture level. As you can see, the implants are all over the place. I mean, that's why sometimes doing it freehand can make things very challenging for you to restore it. Of course, I mean, as a prosthodontist, you are able to find ways to restore things, but probably it's not the best way to restore it. So this patient, once we had the implant position recorded, we went ahead and did provisional try-in. We made some provisional prosthesis. This is a provisional that's been tried in. Make sure the patient is happy with the shape, size, midline, occlusal plane, and things like those. And once you are happy with it, we go ahead and do all this in-house. Again, this is through 3Shape. These are desk components that are placed on the multi-units. As you can see, the implants are coming out from all different directions. So these desk components help, with the help of some multi-units, we were able to correct angulation of some of these implants. And we went ahead and used these desk components, cemented the provisional prosthesis. This is a provisional PMMA, polymethyl methacrylate, milled, and then we tried it in, delivered it that day, and had the patient go home with it. So these are the provisional prosthesis. Patient goes home, she tries it out, make sure she's happy with the way they look. If it is, that's the lip position, incisal edge position. And then these are our milling machines that we use in our school. These are Roland dry zirconia milling machines that we use. And those are the pucks. And once it's milled, this is basically how it looks. It's milled. Go ahead and remove the prosthesis, put it in the centering. This takes almost like a whole day. So once it's sintered, once it comes out, this is how the prosthesis is going to look like. And then we go ahead and use Mio staining for staining and glazing. So you go ahead and stain the prosthesis. Once you stain the prosthesis, you can characterize it the way you want. You can add dark stainings, you can add pink porcelain or pink staining if you have to. And then we attach these desk components with the help of multi-link. That's a resin cement that we use. I'll go ahead and cement them. And then this is a final restoration that has been delivered for the patient. So as you can see, everything is done in-house with the help of digital workflow. There is obviously a lot of conventional workflow that helps us throughout the process, but the digital workflow helps us, have things a lot more predictable. And this is a patient, as you can see, we corrected the occlusal plane. We went ahead and changed those restorations with the help of multi-units. We were able to correct some of the angulations. Now, for all our patients, we typically give an occlusal device at the end of the treatment. This is not the same patient, but I'm just showing you as part of the digital workflow. You can, again, once the treatment is completed, you go ahead and scan the final prosthesis once it's delivered. And then you go ahead and fabricate an occlusal guard that the patient uses and wears it throughout pretty much the night, mostly, because you want to protect your prosthesis. So this is basically an insurance for your patients. A lot of our patients are paying $50,000-$60,000 to get treatments like these, and a simple occlusal guard is going to help them protect their restoration. So this is included in part of our treatment. Everybody goes home with a occlusal guard at the end of the treatment. Now, this is a different case. This is something which we usually send out. I wanted to put it in here just to let you know that what our labs can accomplish. This is a ceramo metal, porcelain fused to metal on a substructure that's been designed and we delivered for our patients. Now, even in this, there's a lot of digital workflow that is involved. Once you have the similar kind of a workflow, once you have a prototype, you go ahead and measure all your dimensions and see how much thickness you have as far as for the supra and the substructure. Once you have that, you can actually design your substructure and send it to, we usually use Nobel to mill our substructure. So we design it and then we send it to Nobel. So Nobel manufactures it and sends it back to us. So it's a big reduction in cost versus sending it to the lab. Something like this, if you had to send it to the lab bill is at least going to be close to $10,000. Whereas if you send it to Nobel, when you design it and have them mill the prosthesis, or not the prosthesis, if you have them mill the substructure, it's probably close to like $1,000. So once that is done, you try in the substructure, make sure it's passively fitting, and then you can send it to your lab to stack porcelain. Of course, stacking porcelain needs hand skills, so your lab has to do that. So that's going to be a big chunk of your financial burden that you have to give it to the lab. But this is beautiful porcelain work that our lab did in the maxillary arch. And then this is the prosthesis that was delivered for our patient, young patient. She had a history of Axenfeld-Rieger syndrome. She lost all her maxillary teeth, and some of them were not congenitally missing. So we went ahead and placed implants on her. She's a 25-year-old. Unfortunately, we didn't have any other choice. She went through a lot of orthodontic surgery. It's extensive. This is a whole lecture by itself, this case, but this is how we finished the case for her. And this is a ceramo metal restoration, the maxillary arch, and some crowns in the mandibular arch. I think that concludes what I wanted to talk for today. I know I had to zip through it just because there was a lot of information. I really wanted to give you as much as I could, just to give you an overview of what we do out here. And as far as digital workflow, you have a lot of freedom. There's just so much you could do. There's a lot of softwares. I think the more you explore, the better you get at it. And I think you can, it's a great service for your patients, and things you can do is incredible through digital technology. With that, I think I finish up. If you have any questions, I'd be happy to answer them for you.
Thank you, Dr. Vinay. Thank you for showing the pinnacle of prosthodontics. You've shown everything from conventional to digital, and from XNAV to photogrammetry and everything. I mean, it's like a very eye-opening for all the final year students. We have undergraduate students along with our residents who are sitting here, and it will be eye-opening for them in a way. And probably they missed out on one thing that you said at the beginning, that it is not completely digital. You need to have your basics right. And you need to know how to do your JR. Then only you're going to get your plane, you're going to get your incisal edge and all those things. So it is, don't worry about your prosthodontics. And probably they are carried thinking that, in 5 years, you're just trying to think that, I'm too much in cost to lab. It's not just plaster and difficulty setting. You're able to see so much that can be done. And sir, thank you so much. Wonderful presentation. And I would like to ask, sir, if there, I think most of the conventional full arch will be immediately loaded, right?
I think I would say 80% of our cases are immediately loaded. Of course, we have to, take into consideration the patient's condition. If obviously implants do not torque well, we do not immediately load, but most of the time we do immediately load because we're preparing them. So what we do is, if we are unable to immediately load, we extract the teeth, have the patient go home with dentures, and then come back at whatever 3 or 4 months. At that point of time, we know for sure we're able to immediately load a little bit, or our chances of immediately loading is a little bit better. So we do that. But for the most part, yes, we do immediately load. Patient expectations are pretty high, but at the same time, you want to set those expectations right. We never tell the patient that you can go home with fixed prosthesis. We always tell there is a very small chance that you can go home with a fixed prosthesis, but there is a high chance that you're going to be going home with a removable. So that way you are, not building up their expectations very high at the same time.
Lowering the expectation, we do that for the CD case also.
Yes.
Sir, I would like to ask you, sir, how much do you get training for residency for using the Blue Sky and all the ExoCAD softwares?
Yeah, so as a resident, there is no formal training as such, but we all have access on our computers to Blue Sky Bio. We have credits that are available. We have 3Shape, we have Implant Studio, we have DTX. So it depends on every resident. So whatever you're comfortable with, I like to try out different kind of softwares just to know. I mean, when I'm outside, I'm probably not going to use all these software. I'll probably stick to one. But as a resident, you want to see and know what is available. One, two is what you're comfortable with. And I think once you try out a few softwares, you can go outside and then try to stick to one. But there's definitely advantages of one over the other. There's no doubt. Not all are the same. But we do not get any formal training as such, but we learn from our co-residents or our colleagues. But once in a while, we do have somebody from ExoCAD. They come in, they'll kind of show you how to set up cases. I think setting up cases is really important. We also have an in-house lab technician. He's very skillful, so he'll help us set up some cases if we have to. But for the most part, we design and do everything ourselves. Yes, it does take a lot of time. Yes.
Yeah, if any of the alumni wants to ask a question, we have a lot of alumni doing exclusive implant practice as well. Dr.
Yes.
Sri, Ashish, Joel.
Yes, I think implants have completely changed the way dentistry has been practiced. I mean, to a lot of prosthodontic residents in CDC, I think trust the process. I know it's tedious. There's a lot of hours that you need to put in, but I think you're going to become the best when it comes to restoring something like this. I think, you have to strive for it. I mean, patients are paying a huge amount of money. They really don't want to do this again. And unfortunately, we see a lot of failure cases that we're redoing. And that's one reason I came into residency. I practiced as a general dentist for 8 years. I really did not do a lot of this. We were doing some full arch restorations, but I really wanted to be skillful at what I was doing, and I really wanted to be very thorough. So it was a kind of a hard decision to come back to school and do pros residency all over again. A lot of my colleagues were like, why are you doing pros? Pros is more like general dentistry. Everybody can do pros, but it's really not the same. So trust the process. It's a lot of hard work, but you're going to become the best at some point.
I really appreciate that. It's good. It's one thing to learn, but one thing to be skillful.
Absolutely. Absolutely. And knowing the analog ways is obviously the best. Digital workflow only helps you go through the process a little bit more smooth. But if you do not know the analog way, there is no way. I mean, if you haven't done a full mouth wax up by hand, you cannot do a digital wax up. There is just no way. So analog is the first way to kind of learn. Once you learn it, you can incorporate your digital. I mean, analog wax up, probably a full mouth wax up might take 5-6 hours to do it. Digital wax up maybe takes probably an hour or two. But if you want it to be perfect, you have to be perfect at your analog ways first. Yeah, so I completely agree with Dr. Nirmal. You have to know your analog, you have to know your conventional ways of doing things, and then you can skip some of the steps, go more digital, make it more efficient, and make it more streamlined.
I think that's a very important point you have re-emphasized. I think many times we think actually, why we need to do a carving in the dental anatomy class.
Absolutely.
I know that each student went through a horrific time of getting that carving right. But
Absolutely.
I think that's the most important step.
I think so. I totally agree with you. And I think working with your surgical colleagues is also important. I think educating everybody, uh, I mean, working as a team for these patients is kind of important. I was fortunate to have some amount of surgical training when I was in India, and but a lot of my colleagues, they work a lot with oral surgery residents, perio residents. I think just educating everybody, just getting, this is more like a multidisciplinary care. It's hard to do everything on your own. As a prosthodontist, you can do some amount of surgery, but you need to have the surgeons helping you out. So you need to kind of help them understand why you want the bone reduction, why you want the implants to come out from the same location, because you've seen those complications. Most of the surgeons, with all their wonderful skills, they help us place the implants, but they're unfortunately not seeing the final outcome. So I think if you share your cases with them, work as a team, I think it'll help all of us get better with time.
And
Thank you, sir.
we have our final years with us. If any of you want to ask a question.
What sir said is very right with respect to trusting the process. 9 years, if you miss the initial part, you should remember that he was a demo in oral surgery, he was a demo in orthodontics. He used to teach us wireprinting exercises. He was in charge of the mobile dental clinic and a mobile dental van that goes out every day. So I think he got a lot of basics right at this place. And now he's, there's one more thing, he's still learning. It doesn't stop. And it's like still he's learning and getting new skills. Thank you so much, sir, for this.
One more. Dr. Poonam, you want to say something?
I just want to ask a question regarding the topic. What are the factors you take into consideration for immediate growth? Any one particular factor?
I think a particular factor as far as immediate loading, most of our cases are done under IV sedation. So as long as the implants start well, we have 35 Newton centimeter on the implants, we're able to immediately load. But there are some cases where the patients are very uncomfortable at the end of the surgery. And if those don't go well, then we decide not to immediately load. We go ahead and place healing or cover screw and close it up and send the patient home with just the regular dentures. But for the most part, if we are able to have good torque on those implants, just because our planning, because we do a lot of planning, very rarely we do freehand. I think that's one reason why we are able to immediately load a lot of our cases. Whereas if you're extracting and not planning ahead of time, I think you have more chances of not immediately loading. But since we are able to plan our implants ahead of time, we know where the bone is. Most of the time we're able to immediately load successfully. And I think splinting implants, as we all know, literature has shown that splinting implants has a very good success rate on the integration and preventing any kind of micro movement and things like those, versus making the patient wear a denture with all the pressure from the denture because it's tissue borne. There could be other issues associated with it. So we try to immediately load, but of course, not all cases, we cannot do that all the time. But in cases we are able to immediately load, I think that's a good service for our patients and also helps us. But if patients are not able to follow our instructions, they're not able to come in for a routine follow-up care, and then we try not to immediately load them because we don't want to jeopardize the implant position and this whole surgery as such.
I think what you said is absolutely right. Working without hands and then going to digital makes a lot of sense. But just jumping to digital world is not what we want in your life, because you don't know what is correct. Whatever is being dictated by the intelligence of the software is what you have to receive. But if you really want to it's what exactly you want, then you need to work with your hands and then only shift to the digital side.
Absolutely. Absolutely. I love doing a lot of analog. A lot of my friends kind of make fun of me because I sit for hours and do a wax up with my hand, but I really love using my hands because it helped me sharpen my skills. If I were to do everything digital, I don't think I'd be good at doing my hand wax up. So we do a lot of full mouth, like crown and bridge work. I do a lot of hand wax ups in those cases. I really can give those lifelike appearances with my hand wax up.
Thank you, sir.
Thank you,
Actually, I believe for the wonderful presentation. Social media is a very powerful tool. We've been friends on Facebook since I don't know ages, but he contacted me seeing the different things happening in college after the alumni meet and all those things. And he said where he's working right now. So I thought, we have a great opportunity to inspire our younger generation, to inspire our department itself so that we can try achieving newer things and showing our PGs, our residents, our future students, what all are happening in the world of prosthodontics. Thank you, sir, for taking out time. I know it's late out there, but you're a hard-working guy. So at the last time also, sir showed me the lab in the University of Maryland, and it was a really wonderful experience. And trust me, he was the only one in lab. He was working very, very hard. Thank you so much, sir.
Oh, thank you. Thank you very much. It's good to see you all. And I hope we can meet up again. And if there's some other questions you have for me, I have my email address, I think, on there, but I can share it with you. If there's something, you can always reach out to me via email. I'll be happy to answer any questions that you have. But again, the only thing I would say is having the foundations right is the key. I think just go slow with implant restorations. You don't have to jump into full arch. Just try to learn everything you can over there. And once you get better at it, as being residents, I think you can do really wonderful work. I think there is just no other better time than to be in dentistry than now. I think you guys are in that high peak of dental prosthodontic care. Basically, this is just gonna go, get better from here onwards.
Thank you so much. Thank you all alumni. Thank you.
Thank you. I'm just typing my email. If there's anybody who has any questions, I can go ahead and share my email address so they can reach out to me. Thank you again, Dr. AB.
Yeah.
Thank you, everybody.